None other than an excellent communicator, Dr. Rajeev Jayadevan. Rajeev has been in this communicative task for the last few years, and we have listened to him. He is going to take the topic of how to feed an IBD person, nutrition IBD, putting theory into practice.
Thank you, Professor Shinoy. Chairpersons, thank you, Anjitroni and team. Nutrition in IBD, putting theory into practice. I have added my own twist to that. In 12 minutes, I'll focus on the things we can do in our own practice from tomorrow. For ease of discussion, I've chosen to classify my talk into 3 segments. Diet before IBD, that is, with emphasis on whether diet actually causes IBD. Diet during IBD, that is, what kind of diet we can advise to someone with an IBD flare. And diet after IBD, after the flare, what do we advise patients? Diet before IBD. So what causes IBD? As all of us know, unlike cholera, which is a mono-themed disease caused by Vibrio cholerae, inflammatory bowel disease is multifactorial. So we can't equate that to a single causative agent. Therefore, diet is just one of the implicated factors. It is said that a diet that is low in fruits and vegetables, rich in fats, contains excessive omega-6 fatty acids, red meat, and processed foods. Such a diet is associated with increasing IBD. There are mentions about vitamin D and breastfeeding being protective agents, and increasing chatter about the role of maltodextrins. More on that. Maltodextrin is a starch derivative. It is seen in almost all modern processed foods. It's basically a powder. It's like starch powder. It can be made from all of these agents, and it's easily digested. It's a polysaccharide, and it's been linked with increasing IBD, in especially Crohn's disease in the United States. Animal models have suggested its influence on the intestinal mucosal barrier. As I mentioned, the multifactorial angle of Crohn's disease. There are so many agents that are implicated, some of which are infective, some are genetic, some are in terms of race, others are socioeconomic status, specific nutrient deficiencies, and so on. In our routine practice, we can say that high fiber diet not only aids digestion, it also decreases the risk of Crohn's disease. This is one of the more conclusively proven facts in IBD. But to summarize section 1 of my talk, I'll say this: no specific diet has been shown to prevent or treat IBD. However, for symptom control, we can adopt some dietary strategies. So what are these strategies? That is, diet during IBD. Why malnutrition occurs in IBD? That is, many reasons. Somebody who has IBD has malnutrition. They may not be eating much, they may lose too many nutrients, their needs are more, they may malabsorb, either from the disease or from medications. So how do you screen? How do all of us screen for malnutrition in everyday practice? A practical method, something that really works, is to have a nutritionist as part of our team. They're very good at their work. They have varying tools to objectively assess malnutrition. Now, if we don't have such a person, or if we want to do our own assessment, we could do what is called the SGA, or the Subjective Global Assessment. If you can see the picture A, a well-nourished person; B, at risk for malnutrition, and C is severely malnourished. SGA is reliable, reproducible, and more importantly, it can identify those who need specific nutritional therapy. I will present an easy bedside assessment tool for busy doctors. Unlike the West, in India we see a lot of patients in a given time. So we don't have a lot of time to sit down with long questionnaires. So here's an easy method. I'm going to present this to you. The first, you observe. Does the patient look malnourished? Is the patient likely to starve in the next few days? As all of us know, anyone who's admitted to our hospitals are on a starvation diet, regardless of the underlying condition. So if these two questions are met, yes, be careful. And the second step is to ask a couple questions. Are you eating well? And have you lost weight? And these two simple steps are almost as good as the more complex questionnaires and screening tools which have fancy names such as MST and MUST. So these are the standard regular questions that anyone would ask someone else when they meet. How are you? Are you eating good? Have you lost weight? So we must warn our patients. Earlier, a speaker spoke about counseling. We must warn our patients about the wrong advice. Many of our patients subscribe to the WhatsApp University of Medicine. Malnutrition is a real danger. The university says don't eat this, don't eat that, and so they are at risk for malnutrition. And protein intake deserves special mention. During an IBD flare, protein requirement is greater, so we must keep that in mind. Watch the protein intake. For an ulcerative colitis flare, we must feed and not starve the patient. And to go through the specifics of an ulcerative colitis flare, low residue diet, and to avoid things that will increase the stool output, more omega-3, less of omega-6. Omega-3 is present in our regular fish, that's mackerel and sardines, and smaller meals. Diet for Crohn's flare is not very different. Most of the doctors do not use TPN except for the most severe cases and also for pre-op rapid replenishment of nutrition. So oral high protein diet will suffice. And to go to specifics, it parallels the ulcerative colitis diet, except that if there are strictures to avoid jackfruit, which is a seasonal delicacy, and also if the patient is lactose intolerant, to advise the patient to follow a lactose-free diet. And Crohn's people, they also have malabsorption, fat malabsorption, in which case we can give such an advice. Exclusive enteral nutrition, as Prashant said in the earlier talk, is almost as good as steroids in a younger child, in a younger patient with IBD. And the way it works is that it has a low residue diet, decreased gut microbiota, avoids long-chain fatty acids, which is supposed to help the macrophages, avoids other normal food ingredients such as emulsifiers, and last is the TGF-beta, which is a protective anti-inflammatory substance naturally found in breast milk. So all of these are supposed to be helpful in EEN, Crohn's flare. Some nutrients of concern: folate, magnesium, calcium, iron, potassium. All of us are aware of the reasons why each of these ingredients can be deficient, and we must customize our own patient for which nutrients to supplement. Going on about other specific nutrients for Crohn's: vitamin D, A, D, E, and K for malnutrition or malabsorption, and then zinc. Osteoporosis was mentioned here by Ronnie. Not everyone, but with IBD, if someone is older, postmenopausal, long-term steroids, a history of fracture, and a low BMI, they are at greater risk for osteoporosis, and these people must be sent for a BMD scan. Diet therapy: remember that some of them may have food allergies, and food allergies must be identified and treated. The top 7 are milk, egg, peanuts, nuts, fish, and others. So these are to be screened for. If the patient has an allergy, specifically diet has to be modified. So the third section of the talk is diet after IBD. What after flare? So how do we reintroduce normal diet? Advance gradually over days. Add fiber as tolerated. Tender cooked vegetables, canned fruits, cooked cereals, whole wheat noodles, chapatis. Remembering that steroid use, which is commonly used after a flare, can increase protein and calcium needs. If the patient wants specific diets, we can say dilute juices, applesauce, canned fruit, oatmeal, plain fish, chicken, eggs, mashed potatoes, rice noodles, bread, which is white. So all these are examples of foods that can be safely given after flare. Some specific practice pointers: no restrictions for diet during remission. Really, no restrictions. Specifically for IBD, the patient has some other conditions such as IBS or lactose intolerance or allergy, yes, there are restrictions. But otherwise, for IBD per se, no restrictions during times of or during good times. Supplements must be customized. For distal ileal disease, B12 and folate. Calcium and vitamin D, we must have a low threshold for prescribing these, and the others, really no definite evidence. Does any specific food item cause IBD relapse? No. Contrary to common belief, no specific food item can cause a relapse, and there is no need to restrict milk as long as there is no lactose intolerance, allergies, or stricture. Stricture, of course, milk can cause bloating, and bloating can aggravate obstruction. So to summarize my talk, the main points, again, geared towards daily practice. 1, let's realize that in IBD, malnutrition is real, and a quick bedside assessment must be done. Those questions: how are you feeling? Are you eating good? Have you lost weight? Are you likely to starve? So those are standard questions. And if the patient looks weak, yes, the patient is malnourished. Do not starve the patient, and we must specifically leave instructions with the treating nursing staff not to starve the patient. And sometimes the patient may starve for other reasons, such as imaging, so we must keep that in mind. Protein requirement of these patients would be higher than usual because it's a negative catabolic state. Involve a dietitian in all IBD patients. Replace specific deficiencies, the ones mentioned. Nutrition is more relevant for Crohn's of small bowel, and if lactose intolerance, to give more calcium, and remembering to check for osteoporosis, and for children specifically, growth failure must be guarded against. Thank you for your attention. Some acknowledgements from my colleagues.
Thank you, Dr. Jayadevan, for a very informative and educative talk for the clinicians. I have only one question to you. You said probiotic, there is no role. But will it do any harm?
Good question, Dr. Narayan. Probiotics, specifically VSL3, has been published, I think back in the late 90s. VSL3 was proposed as a treatment modality for ulcerative colitis. But later, that's really not been continued. As to whether they cause any harm, I do not know. But probiotics, at this point, are not part of evidence-based treatment for inflammatory bowel disease.
Any questions from the audience?